Matt, maybe you can comment for us on your work at Dana-Farber in terms of chemoimmunotherapy with a small molecule inhibitor, and particularly your results with your iFCR regimen.
So the iFCR study at first glance may sound somewhat similar to what we just heard about with iFCG, but actually there are some key differences, and I think it's nice because both of these studies are running in parallel, and we're going to answer some different questions. So with iFCR, we really had a couple of fundamental questions that we wanted to ask, and the first was really, what does ibrutinib add to FCR? And FCR is a regimen that we really have a lot of historical data for, going back 15 years or more now. And so, one of our key questions was, would ibrutinib help to overcome some of the negative prognostic markers that we traditionally associate with FCR, in particular the unmutated IGHV status? And when we started out with the study, we were also interested in seeing if this could overcome the poor prognosis of deletion 17p. And so we actually included some patients with deletion 17p, knowing that with FCR alone, they may not have a good response, but perhaps with ibrutinib, it may be able to overcome that. So in this multi-center study, we've now enrolled 35 patients that we reported at the recent ASH meeting. These patients were treated with the usual 6 cycles of FCR, and the median number of cycles received was 6, so most patients were able to get through all 6 cycles. I think it's important in both of these studies to highlight that these are all younger, fit patients, so all the patients in our study were age 65 or younger. And in our study, we did start with growth factor support as a mandatory thing from the beginning, along with aggressive antimicrobial prophylaxis. So we've got just under about 2 years of follow-up now on our patients, and we have seen very striking efficacy as well. All of the patients did achieve the iWCLL response with about a 63% rate of complete remission. The primary endpoint of our study was pretty stringent. It was looking at the rate of complete remission and bone marrow MRD negativity, so both factors together. And there we saw about 37%, which compares favorably compared to the German CLL study group, where they saw about 20% in their CLL-8 study. But I think one of the things that was striking in our study is that we allowed patients to continue on ibrutinib maintenance for up to 2 years after finishing FCR. And we noticed that responses would deepen over time, and so this rate of CR with bone marrow MRD negativity is now approaching 60%. And I think probably the most striking finding of our study is just looking purely at the bone marrow MRD negativity rate, was 83% looking across sort of the best value for any patient. So, this is a study that included 17p patients, unmutated IGHV patients, and as far as we know, this is the highest rate of bone marrow MRD negativity that we've seen with a CLL regimen that includes all the different risk populations. And all 4 of the 17p patients, unfortunately, did not achieve MRD negativity, and so as we've expanded the study now going forward, we have decided to exclude those patients. But I think outside of 17p, even looking at the unmutated IGHV patients, they've done very well with the iFCR regimen. About 70% of them have achieved MRD negativity in the bone marrow. So these are all kind of surrogates, and really what we're going to be most interested in is the progression-free and ultimately overall survival, which is going to take time. But certainly we know historically with the FCR regimen that the MRD rates are correlating nicely with PFS and OS, so I do think it's a good surrogate for that.
Did you give routine growth factor for your patients on this study?
We did, and in fact, the rates of neutropenia were around 30% or so I think that did help mitigate that. We saw relatively few serious infections, so I think that's been a successful strategy. I think it's kind of a combination of the mandatory growth factor, the infective prophylaxis, and then also the selection of the patient population to a young, fit population.
And maybe comment on the prophylaxis, infection prophylaxis.
Yeah, so we do PJP prophylaxis, typically Bactrim if patients can tolerate it, or tovacone if they can't. We use acyclovir or valacyclovir for HSV-VZV prophylaxis. We did not routinely do antifungal prophylaxis. It's interesting, there have been some fungal infections described in patients on ibrutinib. We haven't seen that in our study, but certainly a risk that we're looking for.
So for this favorable prognosis patient, having a mutated V gene, being young, we're still interested in chemoimmunotherapy. I think there is still value in exploring it. I think our approach has been to minimize the exposure to chemotherapy while still trying to achieve the same results. But I wonder if you can just speculate, Nitin, on what the future holds. Where are we going with treatments? And can you comment maybe on the abstract that you presented at ASH with regard to the small molecule inhibitor combinations and what that looks like and how that may relate to this type of patient?
Sure. So certainly, what we just talked about is the chemotherapy and chemoimmunotherapy with combination with targeted therapy. But certainly there are, drugs such as ibrutinib, venetoclax, and there are other drugs, and there are regimens which are combining these. So at our group, we had initiated now 1.5 years ago a combination of ibrutinib plus venetoclax as a strategy both for relapsed refractory CLL patients as well as frontline CLL patients. And in the frontline cohort, we only included patients who are high risk. So this is different from this patient, particularly, and the patient population we discussed for the iFCG and iFCR. For the ibrutinib venetoclax study, 90+% of the patients were relapsed refractory. 90% of the patients had either deletion 17p, 11q, or unmutated V gene. So they were high-risk patients. And among that group of patients, what we saw is that for the first 3 months, we gave ibrutinib so that the tumor volume is decreased when we add venetoclax. And at month 4, venetoclax was added. And what we saw was that after adding venetoclax, we see a high rate of MRD negativity as well as CR rate, which improved with time with ongoing therapy. So the trial stipulates 2 years of venetoclax, and for patients who are MRD negative, we'll also stop ibrutinib at 2 years. So that's, in my opinion, a very exciting results in the frontline setting for high-risk patients. And certainly one could argue that for patients who are mutated, whether similar results could be achieved with the use of combination targeted therapy. And I think there are several other trials with the combination, not just with ibrutinib venetoclax, but there are several other regimens, including regimens with CD20 antibodies, which are ongoing in the frontline setting. And I think those regimens, as well as the several randomized studies which are ongoing right now, I think in the next few years we'll know more for that subset of patients, such as with mutated V gene, whether there is a role for chemotherapy.
I don't know, Matt, do you have anything to add to the new small molecule inhibitor combinations?
Yeah, I mean, I think the data we saw at the ASH meeting, including your data and several other studies, were very exciting. I mean, the IFC-based regimens that we just talked about really only apply to a smaller subset of the youngest, fittest CLL patients. And I think the promise of the novel agent-only combinations is that those are regimens that many more CLL patients could be eligible for and tolerate and still get great results. I think what remains to be seen with the novel agent-only approaches is the durability of response, because the follow-up does remain short, and we sort of assume that these deep responses will be long-lived as they were with chemotherapy, but we won't know for sure until we have the longer-term data. So I think it's important that we are pursuing both chemotherapy novel agent combinations as well as novel agent-only combinations, and time will tell, I think, what the optimal regimens are for patients.